Welcome to our sonography lecture on abdominal vascular pathology, part 3 of 5. This lecture will cover renal artery and renal vein pathology, including renal artery stenosis, renal vein thrombosis, and Nutcracker Syndrome. As a general sonographer, you may or may not be required to perform renal artery stenosis exams. If you have a vascular ultrasound unit associated with your hospital, quite often the abdominal vascular work does go to the vascular unit. However, if you're scanning an abdomen for a multitude of reasons, you may come across kidneys that don't quite look right and resemble kidneys that are affected by a renal artery stenosis. So if you know the basics of what happens when renal artery stenosis is present, and you'll be able to help the patient get the right tests they need. So let's take a quick introduction/review to the renal artery stenosis pathology. So renal artery stenosis is basically a narrowing of the renal artery. This most commonly occurs because of one of two things. The first one being arterial sclerosis, where the vessel walls harden and plaque develops, therefore narrowing the artery and how the blood flows through it. And this is most commonly going to be seen in older men. The other more common reason is something called fibromuscular dysplasia. Now this is going to be seen in younger women typically, and what happens is that the muscle wall becomes more rigid, more fibrous, and when that happens, the walls kind of crunch down on themselves, causing that narrowing. On ultrasound, we call it the string of pearls effect. It looks like little balls along the length of the vessel. If the narrowing is significant enough, then it's going to change how blood flows in the kidney. So we will see that with our Doppler samples. We can see that how the kidney appears in itself, and we'll see it clinically with how the body regulates its blood pressure. So patients who are most likely to have renal artery stenosis are those that have a history of smoking, high blood pressure, high cholesterol, or diabetes. All of these are more precursors to arterial sclerosis, and because all of these affect any arterial vessel within the body, the renal arteries are not immune to the effects of these precursors. Now, the most common reason that a person has a renal artery stenosis exam ordered is because they have blood pressure that does not respond to treatment. There's tons of medications out there that can help the body regulate blood pressure, but the kidneys also play an extremely important role in it. And when that medication doesn't work quite the right way, we start to think that it has something more to do with the kidneys because that medication isn't working appropriately. On ultrasound then, we are going to be able to see quite a few of the indicators that might lead to a renal artery stenosis diagnosis. We might be able to see stenotic waveforms within the actual renal artery, so that is called the direct method, where we actually see the stenosis in the renal artery. Or what we might see are tardus parvus waveforms in the parenchymal arteries of the kidney. And this is considered the indirect method, where we're looking at how blood is flowing within the kidney. Another tool that we have is something called the renal aorta ratio, and that is where we compare the peak systolic velocity seen within the renal artery and compare that to the peak systolic velocity seen within the aorta. That should not be greater than 3.5. So for example, say we have a renal artery peak systolic velocity of 300 and our aorta peak systolic velocity is 65. That 300 compared to 65 is greater than 3.5 times the peak systolic velocity in the aorta. So that is also indicative of a renal artery stenosis. And another thing that we might see probably more commonly in the general lab is that when the blood flow does not flow to the kidney as it should, that kidney starts to become hypertrophic. It becomes small and echogenic. And so that might be something that we notice during our abdominal exam, our liver exams, right upper quadrant exams. And because we know the basics of renal artery stenosis pathology, we might actually be able to figure out that this patient needs a dedicated study to rule out renal artery stenosis. So let's take a look at the renal artery stenosis protocol. First off, you want your patient to be NPO for at least 8 to 12 hours. The reason behind this is because the renal arteries are actually really difficult to see. They travel between and under other abdominal vessels, all of which is surrounded by bowel. So we really want to eliminate as much gas as possible. We're going to start the renal artery stenosis protocol with taking standard grayscale images. So that does include all of our long and transverse images that we normally take. And we want to make sure that we are measuring the kidneys so we can compare their sizes to evaluate for any sort of hypertensive atrophy. It's typically easiest then to start with the indirect method to evaluate for renal artery stenosis. When we are using the indirect method, we are using color and Doppler sampling from inside the kidney. We are either going to sample the segmental arteries that are the first branches of the renal artery, or we will look at the arcuate arteries that are found out in the parenchyma. We typically evaluate then the superior, mid, and inferior poles of each kidney. Using Doppler then, you will place the sample gate within the vessels and get your spectral tracing. Once you have your spectral tracing, you will want to measure the peak systolic velocity, which is the fastest velocity that is seen through the vessel, and the end diastolic velocity, which is the speed right before the next uptake. We then can compare the PSV and the EDV to one another in something called the resistive indice. The resistive indice is taking that peak systolic velocity, subtracting the end diastolic velocity, and dividing that number again by the peak systolic velocity. When you have a normal RI within the kidney, it should be less than 0.70. Anything greater than this is suggestive of renal artery stenosis. The other thing that we are looking for as well then is something called a tardus parvus waveform. Typical renal arteries have a very quick upstroke and have a very sharp peak. In the tardus parvus waveform, we see what we have in this picture here, more of a slow, rounded peak, and that is also indicative of renal artery stenosis. We also want to evaluate the renal vein to make sure that it is patent, so we will use color and Doppler to show that there is blood flowing through the renal vein at the hilum. And then we will want to turn our attention to the actual renal artery to perform the direct method. Some tips and tricks that you can use to evaluate the renal artery is to turn the patient onto their side, so to cube the patient. Try looking at the renal artery both in long and transverse planes. It does not matter which plane you use as long as you are able to see it well. Make sure to increase your color gain so it really sticks out within the abdominal tissue. You may want to decrease your color scale. Again, that will bring out the fast speeds of the renal artery a little bit more prominent in your pictures. Once you're able to visualize, you'll definitely want to optimize your image so you can evaluate for any stenosis or turbulent flow. You'll also want to zoom into the area. Make sure that you are enlarging that area using magnification to make it larger and easier to see. You'll also want to know the normal course of your vessels. The renal arteries typically take off of the aorta just inferior to the superior mesenteric artery takeoff. And remember that the right renal artery does travel posterior to the IVC, which can sometimes make that area difficult to evaluate. So to perform the direct method, you will want again to use spectral Doppler and color Doppler to take samples along the length of the renal artery. You'll typically take about 5 pictures along the length, one at the hilum, where the renal artery enters into the kidney, distal, mid, proximal, and origin of the renal artery should also be assessed. The origin is where the renal artery leaves the aorta. If your color is set appropriately, then you may notice some areas of turbulent flow, and you will want to make sure that you're sampling within those areas as well. Whenever you're doing the direct method, again, you want to look at the peak systolic velocities and the end diastolic velocities, and we want to look for any stenosis indicators such as turbulent flow, filled in windows, or elevated velocities. Once you've evaluated both kidneys and both renal arteries, the last thing that you'll want to do is evaluate the aorta at the level of the renal arteries. You'll take an image of the mid-aorta and lung with a color and spectral Doppler tracing. You'll want to measure the peak systolic velocity so you can compare it to the peak systolic velocity in the renal arteries and evaluate the renal aorta ratio. This slide here shows us some abnormal velocities within the renal artery, indicating a renal artery stenosis. We can see that the velocities are extremely high in the top pictures, exceeding 500 for peak systolic velocities, where we can see on the bottom more normal appearance where we have velocities in the 100s. And that is the end of our review of renal artery stenosis. You will study this more in depth in your vascular classes, and board questions will be more prevalent on your vascular boards. However, you do need to know the basics of renal artery stenosis and how we diagnose it for your abdominal boards as well. Let's change gears then to the renal vein. The renal vein, just like any other veins in the body, are susceptible to thrombosis. So when this occurs, that is a blood clot that is found within the renal vein. Renal vein thrombosis is typically seen with renal tumors, trauma to the kidney, infections of the kidney, and after a renal transplant. Patients who have renal vein thrombosis are typically going to have pain on that side and some blood within their urine. On ultrasound then, the kidney is actually going to look really heterogeneous. There's still blood coming in through the renal artery, but it's getting blocked up within the kidney. So the kidney doesn't really know what to do with all this extra blood, and it starts to have issues with that overload of blood, making it appear heterogeneous. The renal vein will also appear large with internal contents. The clot is not always seen, especially if it's an acute clot. Those are typically anechoic. You'll want to use color and spectral tracings to prove that there is no blood flow within the renal vein. In this image here, we can see an example of renal vein thrombosis. We have the kidney in transverse. We can see the vessels crossing the hilum. We have the renal artery here, but at that proximal portion of the vessel, there is no blood flow, and they are using a spectral tracing to show that there is no flow in this area. This is not maybe the best window because we can see that the renal vein is traveling horizontal to our ultrasound beam, so you want to make sure that you are using different windows, using physics to your best ability to prove that there is no blood flow within the vein. This is an example of a kidney and how it can appear more heterogeneous in the setting of a renal vein thrombosis. We can see that there are very echogenic areas, kind of a mottled appearance to the parenchyma. Our last pathology regarding the renal vessels then is the Nutcracker Syndrome. Nutcracker Syndrome is a rare disorder in which the left renal vein is compressed in between the superior mesenteric artery and the aorta. If you recall your anatomy, the left renal vein leaves the hilum and courses towards the midline, towards the IVC, and goes in between the SMA and the aorta. If the SMA takes a different path off the aorta than it typically does, it can then compress the renal vein and kind of smushing it in between the SMA and the aorta. Clinical signs and symptoms associated with Nutcracker syndrome include blood in the urine, protein in the urine, left-sided pain, and pelvic or scrotal pain. Now, when that Nutcracker syndrome is present and the renal vein is being compressed, again, that means that blood is not leaving the kidney as it should. And so the blood that is coming in kind of gets backlogged into the kidney, and the kidney becomes overloaded, causing the blood and protein in the urine. The other thing that we see with Nutcracker syndrome is the presence of pelvic or scrotal pain. If you recall the venous drainage of the gonads, the left gonadal vein drains directly into the left renal vein, where the right gonadal vein goes directly to the IVC. So when the left renal vein is being compressed, causing a slowing or a blockage of the outlet, that can back up then into the left gonadal vein, causing swelling and pain in the pelvis or scrotum. On ultrasound, we should actually be able to see the visual compression of the left renal vein, and there will be increased velocities and pressure within the left renal vein on Doppler. So here's an example of Nutcracker syndrome. This is a transverse view at midline. We have the superior mesenteric artery here, we have the aorta underneath it, and we have the left renal vein coursing in between. We can see that the diameter of the left renal vein greatly changes as it courses in between the aorta and the SMA, showing us that compression occurring here. Here's another example. We have the SMA and the aorta. We have a very large left renal vein that quickly decreases in size as it courses in between the SMA and the aorta. Another example, we have the left renal vein, very large, starkly decreased in size as it travels between the SMA and the aorta. This sample also shows us a Doppler waveform taken from within the left renal vein. We can see that these are very high pressure velocities. And that brings us to the end of our renal vessel pathology. Up next, we'll talk about portal pathology.